Hi, everyone, and welcome. My name is Ellen McNally. I am the Marketing Director at MDeverywhere. And those of you who may not be familiar with MDeverywhere, maybe this is your first webinar with us. MDeveryware is a single-source RCM and EMR solution provider with technology and best practice medical billing services that are proven to improve the claims process, decrease denials, and increase collections an average of about 10 to 15%. I do want to thank you all for joining us today. We have a very diverse group on the line, and our webinar is on payment reform, physician reimbursement beyond fee for service. Lots of changes happening. We'll be on the call for about 60 minutes today. Our presenter, Bert Orlov, is a partner with Integrated Healthcare based out of Connecticut with over 20 years of consulting experience in our healthcare industry. During his 11 years with Integrated Healthcare, Mr. Orlov, or Bert, we'll call him Bert, has led numerous projects for physician practices, thanks Bert, for both private and academic, hospitals, and medical and dental schools. Bert brings academic, operational, and strategic perspective to bear on his work with healthcare providers, and his understanding of both the hospital and physician perspective underlies his strategic and organizational approach to problem solving and management of complex projects in the industry. Achieving measurable results for clients represents Bert's measure of success, and he'll be sharing his perspective on payment reform with all of us today. Before I do turn the mic over to Bert, I do want to cover a couple of housekeeping points with everybody. First off, this webinar is being recorded, and the recording, along with a copy of the presentation, will be shared with all registrants in a follow-up email. We'll also be following up with any questions that might be asked that we don't get to answer on the call, but I'll talk about that a little bit later. We will be muting you during Bert's presentation. As I started to mention, we have allowed time for questions and answer. We want to encourage you to participate. This can be a confusing topic, so send over your questions. If you're thinking it, someone else is also. Type your question into the questions chat window that's on the lower part of your control panel as you think of them, and at the end of the call, we'll answer as many of them as they can as time permits. Any of them that we don't get to live, we will follow up with afterwards. We won't leave you hanging out there, okay? During the webinar, we're also going to be looking for your feedback. We're going to be posting 4 different survey questions during the presentation and truly encourage all of you to participate. It will help Bert deliver his content and adjust his content to what's happening in our audience. Right? So without further delay, I am going to hand over the mic to Bert Orlov for his presentation on payment reform, physician revenue beyond fee for service. Take it away, Bert.
Thank you so much, Ellen. It's always a pleasure to work with you. So good afternoon, everyone, and welcome to this session. We will be talking today about both the context for healthcare market changes and some of the details about changing modes of physician reimbursement, and then we'll be ending with some discussion about what the implications are for you in your various roles. I understand from Ellen that we have a very diverse group here, from physicians to executives to reimbursement professionals, network organizations to small practices, primary care through a wide range of specialties, and an array of geographies. Therefore, I am going to do my best to balance between the high-level context and some of the details. I imagine that some of you will have questions that go beyond that. We'll look forward to answering those afterward. So as Ellen kindly introduced me, I want to emphasize that the thrust of our work is in the realm of physician practice. That ranges from operational details such as the process flows and policies and procedures for MAs or front desk people, all the way through assessment of economic performance and performance enhancement to the highest level strategic enterprises, mergers, acquisitions, addition of lines of business. So we're on the ground every day seeing how these changes are occurring. Next, please, Ellen. So with that as context, I'd like to review our agenda. So one of the places I want to start is with the context point that we've entitled this presentation Beyond Fee-for-Service. But it's important to remember that fee-for-service is not going away tomorrow. It will continue for many years to be a core part of our business, which actually makes life even more challenging because we have to adjust to new opportunities and requirements and demands, even while maintaining the realities of a fee-for-service environment. Furthermore, based on your specialty or your geography or your organizational structure, the changes that we will be addressing here will occur over different periods of time in your local environment. And last, I'll say, some of this, for those of you who are not yet encountering some of the impact that we're going to talk about, I will note that markets more recently in the last several years have seen change not necessarily on a smooth, gradual basis, but sometimes markets that looked one way in the space of a year consolidate and transform dramatically. So what may not sound all that relevant yet could be coming to a market near you surprisingly soon. With that said, as I noted, I'm going to spend part of our time discussing the context for these changes, then providing some of the detail about how these new reimbursement structures work and what the financial implication is. And then we're going to end spending about the other half of my time talking about the implications for individual practices and networks to accommodate and to optimize financial and operational success under these new rules. We will touch on Medicare because where the government programs go, the rest of the market tends to follow. And Medicare and Medicaid amount, as many of you probably know, to almost about half the dollars being spent in healthcare today. We'll talk about commercial plans and even employers, what they're thinking about, how they're adapting to the market, and what their economic drivers are. We'll also talk about how the market is expanding in light of the Accountable Care Act and who now has coverage and how that may influence some strategic elements of your practices and the reimbursement implications that follow from them. Next, please, Ellen. As you can see from this chart on the left, I think it wonderfully sums up the context. And again, thank you, Ellen, for finding this wonderful illustration of the challenge that the American healthcare system faces. And that is that without material change in the way care is delivered, the cost of healthcare is projected to grow for the government in this case from today's roughly 5% to almost 20%, more than tripling the cost unless interventions are changed. That point is key. You may think, well, reimbursement reform, how does this fit in? And the answer is, of course, that all Medicare and commercial payers are all operating in a context of increasing pressure within the government and from employers and citizens to control the rate of healthcare cost growth. So new structures are being employed in an effort to control this growth. And that growth should be understood, we believe, in a larger context. If you look at healthcare spending in the United States on a per capita basis, it is approximately double what is being spent per capita in other developed countries, Germany, Japan, Australia, France. And interestingly, the data from a public health perspective shows no higher performance in the United States than in those other countries I mentioned. And I'm using metrics such as life expectancy at birth, infant mortality, death rates from certain diseases in different age cohorts. So we're spending a lot, not getting materially greater value, and solutions are being sought. And a lot of that solution is believed to come from restructuring of the form of reimbursement. As you all know, the bulk of today's activity under fee-for-service is the more you do, the more you get paid. Now, interestingly, in the past several years during the recession, there has been a slowing of that growth rate. Now, I didn't say that there is reduction. Rather, the growth rate is slowing. There is vigorous discussion about whether that is a permanent trend or merely a reflection of concerns about resulting from the recession. I believe that it is the beginning of a shift of bending the curve. And that, I believe, is important to our discussion today because it will only reinforce the imperative as viewed by Medicare and commercial managed care plans to continue to innovate and advance these solutions that we're going to be discussing in a few moments. Obviously, another key element of the context is the implementation of the Affordable Care Act. And that is now a reality. Depending on the estimates you look at, the data would suggest that there are an additional roughly 1.5 to 2 million commercial enrollees have signed up through the healthcare exchanges, and another 1 million to 1.5 million Medicaid recipients. That is less than the target. If we continue to see that grow, what that means is that there are substantially higher numbers of enrollees, and again, that varies by state market. As we discussed, insurance companies, in addition to the cost growth, face increasing pressure from their clients' employers or direct enrollees to keep costs under control. And the Affordable Care Act constrains their profits, so they have to be efficient. I also think that it's important for those of you who may not be aware to understand that physicians are turning from entrepreneurship to employment. In the past 10 years, there's been a flip, so that if you look at today's graduates of residency programs, approximately 80% of them are choosing employment track positions rather than partnership track positions. I think that's important because that suggests organizations will be assumed to have greater control over the performance of individual physicians, and the incentives will be designed under that assumption. So I think what's important is for the many of you on the call who are in private practice, you will be expected to perform as if you were a large enterprise, not a small entrepreneurship. And that will put greater pressure on your practice patterns and create new challenges. But with those challenges, there are opportunities. The new forms of reimbursement that we'll be discussing in detail in a moment create incremental performance-based revenue opportunities for most of you. And some of you are already seeing them or see see them right on the horizon. Others of you are just hearing about them. Even if that's the case, planning for them is the best position to be ready when it comes. And even if it's already come to you, we're just at the beginning stages for most practices where these innovations represent only a small portion of your business. Next slide, please, Helen. So turning then to an understanding of Medicare, which, as we noted, has over 50 million enrollees, we see, just looking at Medicare, that risk-sharing programs are growing dramatically within the Medicare universe, which is really quite a dramatic shift because Medicare has been the historic bastion of the fee-for-service structure. I'll talk somewhat about the biggest programs focusing on physicians are ACOs, Accountable Care Organizations, PCMH, Primary Care Medical Homes, and the growing reality of Medicare Advantage, that is, Medicare recipients who are part of managed care organizations rather than part of the straight fee-for-service system. So starting for a moment with Medicare Advantage, there are approximately 52 million Medicare enrollees in the country today and about 15 million in Medicare Advantage plans. That means that within constraints established by the government, the plans can adjust their compensation structures and the amount of risk sharing with providers. So what we see is that an increasing number of Medicare Advantage plans are adjusting the compensation that they offer. Say, let's use primary care as an example here, adjusting depending on the market and the number of enrollees. There are reward metrics such as hospitalization rates, quality of care, mammography consistency, management of diabetes, a number of clinical measures and economic measures that can drive changes in Medicare Advantage reimbursement that in markets can range from, say, $50 per member per month for those of you dealing with capitation where you're no longer paid by these plans for individual visits. That number of $50 per member per month can go as high as $100 per member per month for those practices that can demonstrate superior outcomes and greater value. We'll come back to this term value. It will occur a great deal in our discussions today. But again, that difference for primary care can range from $50 up to $100 per member per month. Primary care medical homes, this is in Medicare. What the idea here is that to go back to, if you will, in some ways an older form of primary care practice or more traditional form, where the primary care provider was really in charge of the whole continuum of care, really responsible. And the idea of becoming a primary care medical home is that physicians will spend more time with each patient and not just focus on dealing with problems as presented in an office visit, but rather, more broadly, their entire scope of health care status and needs. And by the way, within the primary care medical home construct, we may see more role for non-physician providers and members of your teams to achieve the results. What we're seeing is that rate enhancements can be a solid 10% for medical homes, and there are new services that become billable as part of healthcare management. Finally, I'll speak to accountable care organizations. Fundamentally, the principle of an accountable care organization is that Medicare assigns a group of enrollees. Their cost base is calculated. Given their age and acuity and medical conditions, their anticipated future expenses are projected. That becomes a benchmark. And any organizations that can successfully control the costs relative to the expected level can share in the savings. Today, there are approaching 500 ACOs. These only started in 2011, so hence it's a risk-sharing growth chart, but it's also an ACO growth chart as well. And just for context, some of the early results of ACOs are very interesting. In the pilot program, approximately 1/3 of the participants exited the program. They could not achieve savings. Another 20% achieved savings, but not enough to share in them, because the way ACOs in the Medicare world are structured is that you have to hit 2.5% savings in order to share. But then for those roughly 40% of plans that have seen savings, they are able to share it. Now, the formulas can range from a few $1,000s to tens of thousands of dollars per physician, because the savings dollars can be in the millions for ACOs as a whole, which integrate physicians with hospitals and other providers. So those are just some critical examples. A couple others that I'd like to mention that are also important, I believe. Meaningful use. Many of you are struggling to make sure that you're able to report the data for e-prescribing, etc. And more pay-for-performance is going to roll out in 2016. Using the example of meaningful use, that can represent, for an individual provider, $15,000, $20,000, $30,000 if done effectively. A new challenge to add to your already extensive to-do list. And I just want to note quickly that lest anyone doubt Medicare's seriousness, it's not just physicians. They're substantially looking at hospital reimbursement and costs. That's important because hospitals drive big dollars. Value-based purchasing, again, this term that we hear bandied about so much, value-based, the quality of the outcome given for the cost, is driving the reallocation of somewhere on the order of $1 billion in hospital reimbursement this year, or rather last year, from one provider to another based on certain metrics of outcomes. Another growing area is readmissions penalties. Last year, we saw about $300 million of penalties assessed to hospitals for patients being readmitted for the same DRG, the same diagnosis, within 30 days of the original hospitalization. And that was only for 3 pilot conditions. These numbers are going to grow dramatically. That's going to hit hospitals. That's also going to prompt hospitals to put a great deal of pressure on their physician base to be following up, to be preventing readmissions, to be engaging in more collaborative care along the full continuum of care. And that will drive changes in the reimbursement and the support from the system to those who can manage costs effectively. Ellen?
Thank you, Bert. All right, to everyone on the audience, this is your turn to participate. We're going to be launching our first survey question here. You'll see it on your screen in just a moment. We're looking for information. Are you part of an ACO or any other risk-sharing network? Yes, you are already. You're planning to. You have no plans to, or no, you're not. All right? We've got about 30% of the audience voting. We're up to 53%. Okay. We've got 70% voting. We'll leave it open for another 5, 4, 3, 2, 1. All right. All right, Bert, with about 85% of the votes in, we've got 31% who are part of ACOs already, 14% planning to, 7% with no plans to, and 48% no. So it's pretty diverse.
Thank you, Ellen. So I think that reinforces the point. Some of you are there and dealing with this. Some of you are expecting to. A bunch of you haven't seen it yet. May take a while, may come faster than you would expect. Next, Ellen. So we also said that another key context point was the expansion of the market. I already shared with you some numbers that estimates range from 4 to 6 million new enrollees in Medicaid and commercial health plans. That is expected to grow. And that obviously has implications, that the size of the market, the number of people seeking care, and how they seek it. Another reality of the Affordable Care Act is that there is more requirement for standardization of plans. That hopefully will mean somewhat easier time for those of you in the billing world, and authorizations will become more consistent. What services are covered and not will become more consistent. We also see that there is a substantial number of new entrants into the market. That means you may be dealing with plans that haven't existed, co-ops, various different entities that will be trying to figure out new strategies to be successful. And ultimately, another thing that we see in this array of bronze, silver, gold, and platinum plans, and throughout the industry except for Medicare, is more cost sharing. Patients have to pay more for each service. This influences the discussion that providers have with patients and has the potential, it is hoped by managed care executives, has the potential to reduce utilization of ancillary testing and procedures because people will choose not to spend their money on them. Now, this is all very new, and so it may sound highly hypothetical to your ears for those of you who aren't in ACOs and seeing it really happen, or even in small ACOs where it's a small piece of your business. But there are we can take some lessons from case studies or from what's happened already. Now, one thing to start, interestingly, the whole primary care medical home, we've seen very different sets of data. Some data sets suggest that there's a 10%, up to a 10% savings in cost per enrollee associated with the medical home concept. Other pieces of data, some came out just yesterday, that suggest that's not the case. It's all very new and raw, and so we counsel our clients not to take any one piece of data too terribly seriously because it's all moving and changing so rapidly. But from the 2006 Massachusetts Universal Care Law, we do know a couple things that are critical. That, one, the demand for primary care goes up dramatically and really puts great pressure on primary care and, to an extent, therefore, frontline specialists. We also know that just ensuring universal access does not per se drive down costs. Massachusetts is now entering its second phase with more of a focus on costs. So we know that just doing more of the same doesn't bring down costs. So there'll be new efforts focused on that. There was a 2011 study in Oregon that, when it expanded Medicaid, that interestingly showed an increase in use of emergency room services. This is not what was expected. So it underlies the point that we are in unknown terrain, but going back to that chart at the beginning, the projected growth is not sustainable. Everyone agrees with that. The fee-for-service incentives are not consistent with the idea of value, and these initial results suggest more and more focus on value. I think it's also worth noting that Medicaid, historically a piece of the business avoided by many or most private practices, may warrant reexamination because most Medicaid recipients are in managed care plans, and for certain specialties, primary care, OBGYN, for example, the reimbursement can be, if not great, certainly good enough to warrant consideration for inclusion in your business. Next, please, Helen. We also want to tie in this broad context that we've laid out to the rest of the market beyond Medicare. It is important to know that commercial plans are innovating how they are working with providers to control costs, deliver higher quality, higher value to their customers, who are mostly employers, and through the healthcare exchanges, individuals. We know that the ACOs do not exist solely to serve Medicare. About half of the about half of the 500-odd ACOs out there today serve commercial populations. They are focusing, both the ACOs and plans in general, are focusing on developing quality and value metrics. When managed care plans are selling their services to employers and individuals, they want to show the value for the cost being paid. We're seeing more and more emphasis on the full continuum of care, including subacute care, creating new opportunities and new coordination challenges for all of you serving patients. Finally, to the specialists on the call, of particular interest is packaged pricing. For selected procedures, we are seeing substantial growth in situations where a fixed price, I'll make up a number, $2,000 for a given, let's say, a knee, will be shared between a hospital and physician groups, and if they can keep the cost lower than that fixed price, the savings are available to be shared between the two. I also want to note that in addition to managed care plans, that employers are driving change themselves. They're creating exclusive provider organizations. They're pushing for primary care medical homes. For example, General Electric Company has pushed its insurers in the Cincinnati market, where they have a large employee base. They've insisted on primary care medical home model, and they believe their data shows significant cost savings as a result. We're also seeing, and this is particularly important, I think, for specialists, the growth of national contracts. As an example, Walgreens has inked a deal with Mayo to direct certain orthopedics to Mayo from across the nation. So for specialists, competition is no longer just your neighboring provider, but providers nationwide, and they're looking at outcomes and costs, again, value. Ellen, I believe you have another poll for us.
We do. We're getting ready to get audience participation again. So you should see the next poll question pop on your screen. Take a second. Are you currently in or considering participating in capitated contract, shared savings, or practice price arrangements? Currently in, been approached or discussing it, not there yet. Come on, let's get a few more of you voting. Get your entries in. We've got about 50% of the votes in. And we're up to 60%, 66%, big jump. We'll give it another 5 seconds. The rest of you want to let us know, are you currently in or considering participation? With 66% of the vote in, I'm going to give it 5 more seconds. 4, 3, 2, 1. Bert, what we're going to find here is that 55% of those that participated are not there yet. 23% in and 23 discussing.
Okay, so that reinforces, and for those of you who aren't in, I would submit that now is the time to be planning to get in, because these type of arrangements will hit your market sooner or later, and the better prepared you are for them, the better you will experience your future financially, clinically, and in terms of the satisfaction of your controlling your environment. Now, having laid a context of the causes and some of the specific examples of change going on in the market, of the number of dollars and potential revenue opportunities that arise from this in specialties or in primary care, we want to turn to the questions, what does this mean for you? Now, many people have said similar things in different ways, but there are a defined number of imperatives that those of us active in the physician practice market see coming out of all these changes in reimbursement methodologies. First of all, in order to understand what's happening to your patients, it becomes critical to integrate your systems from billing and scheduling through EMR to reporting. Data becomes essential if you are increasingly held accountable in one form or another for delivering value, meaning a lower cost for a better outcome. For primary care doctors, we see that looming very directly in terms of downstream costs. For specialists, as this data becomes greater, Medicare is going to be publishing data, and managed care plans are already circulating data on the cost effectiveness and quality performance of specialists. So being able to produce value and demonstrate that becomes essential. And that, again, that spans the gamut from small to large practices, primary care, through all specialties. Now, in order to generate value, we are seeing increased attention on protocols. Now, many people historically in the industry, many providers have historically loathed the term. They've called it cookie-cutter medicine. And there are dangers of over-reliance on it. But there is increasing effort to improve the quality of protocols and use them as a tool for patient management so that costs can be controlled and outcomes demonstrated. So to a certain extent, we would submit that even if you don't like the idea of protocols, you'll be facing a market that is demanding more adherence to patient management protocols for specialists, disease state management protocols for primary care and frontline specialists around broad disease states such as heart failure, diabetes, obesity, high blood pressure. These things together are driving new approaches to patient-provider interactions. Now, the caring part of healthcare is and has always been centered on the relationship between provider and patient. What we're seeing is the need to integrate discussion about economics into these interactions, to reinforce follow-up, reinforce compliance with treatments, and adding new dimensions to the conversation that takes time for providers. That means that you need to bill for it, you need to track it, and to adapt to it in terms of how you operate your business. Now, some examples of tracking that become so important: compliance with medications. You will be facing increasing sources of information about whether your patients are, for example, staying on their medications. And the pharmacy benefit companies are working on their data to be able to inform you if Mrs. Jones has not refilled her prescription in several months. Well, then she's obviously not taking it. Has Mr. Sanchez gone for his PT or not? You will be getting more of that kind of information. You'll also be seeing data about patients going to ERs or urgent care centers. Have they had hospital stays? And if so, how are you as practitioners going to be leaned on and expected to follow up with them to prevent readmissions, to improve the value that's being delivered by you and your colleagues in the healthcare system? And you're going to be expected, while tracking all this data, a new burden on you economically and operationally, to devote resources to reaching out to patients, nursing call centers, etc., for those patients who aren't compliant, who are at risk, who do need to be cajoled to do what is necessary to ensure their health. Now, how, again, this all fits into the revenue cycle is the lifeblood of all of our businesses. Cash remains king. We have to bill and collect effectively. We have to know, under all these various emerging arrangements, what is expected of the providers, what data will be required when you're looking at billing and collections, what should your bonus be, what are you at risk for. So tracking all of these elements ties deeply into your day-to-day work, the accuracy of your EMR, and the effectiveness of your billings and collections operation, not to mention other emerging challenges such as ICD-10, which is going to represent a huge challenge to providers that really haven't gotten ready. Now, there are obviously lobbying efforts to delay implementation, but those will only go so far. So we come back to, in summary, that the changes in the marketplace and these reimbursement methodologies are going to impact patient relationships, referral management. They're going to drive clinical protocols and a need for data. And that data is infrastructure and tracking. And those are some of the key challenges that you will be seeing, whether you're in primary care, tracking your own data, your own risk-sharing gains or revenue opportunities, or specialists looking over your shoulder, understanding that systems that include you in their networks, primary care or frontline specialists who refer to you are going to be looking at data about your value delivery, the cost relative to the outcomes. With that, Ellen, I believe you have another poll for us.
We do, and to our audience, this is going to be our final poll for this webinar. We're actually going to run this one in 2 sessions. So primary care physicians or primary care staff members, you're up first. All right, so we're asking for our primary cares, are you now or are you considering a medical home model? You're currently a home model, a medical home model, thinking about it, or not considering it. Right? So if you're in primary care, this is your time to let us know what you're doing right now. Wow, and the vote is split right across, 33% currently. There we go, a little bit more variance. Okay, primary cares. We've got about 60% of you not considering a medical home and split on currently and thinking about it at 20% each. All right, we'll do 5, 4, 3, 2, 1. And now we're going to flip to our specialists. All right, and for our specialists, we're going to give you a chance. If you're a specialist, I didn't launch it, did I? There we go. All right, if you are a specialist and we want to know if your primary care practices are currently a medical home, if they're not a medical home, or if you don't know. Okay? If you're a specialist, you're voting now. Are you referring primary care practices medical homes? or likely to become medical homes. All right, we've got about 40% of you voted right now. All right, and again, this is just for our specialists. And right now, it looks like, according to these numbers, about 40% don't know if their PCPs are medical home models. 47% know that they're not a medical home model, and they have about 13% where the PCP is a medical home model. So we'll close this out, and we'll get ready to wrap up with the summary. Thank you all for participating in that.
Thank you, Ellen. Next. So from that data, this is about integrated, but I will actually move right on to the next slide, please, Ellen, to follow up on what your votes just told us. It sounds that a majority of you are not yet in markets where you're having to face medical homes, ACOs, package pricing. There's still, it hasn't yet fully happened to you. We, IHC, in consulting to our clients, take a three-step approach to thinking about where our individual clients are, the challenges they face, and how best to meet them. We believe that it's important to set a fact base, which we call an assessment, to understand where your market is, where your practice is, and the timeline with which it's likely to grow. An assessment might include, for example, with specialists, understanding what their incentives are as they think about referring to you. I'm going back to that large proportion of specialists who don't know what their PCPs are doing. Then, and in an assessment, we address strategy, relationships to payers, relationship to other providers and groups, your operational processes, your technology and infrastructure, and your physician and staff skills and what training needs they have. All of these things come together in our work with our clients to generate performance improvement plans. Your performance may be good now, and so this may be focused on adapting in advance to likely future pressures. You may be facing challenges today that need a response. We work with our clients to develop plans in both of those scenarios. And then good planning is only as good as the implementation, and implementation is only useful, it is only viable if you track it. As a nurse colleague of mine many years ago said to me, if you can't measure it, you can't manage it. And these themes all come back to the core idea of preparing your practices, and it sounds like about half of you have the opportunity now to really be preparing your practices for these challenges in the future. Ellen?
Bert, did you want to talk a little bit more about IHC, or we're good with that?
I think we're good. I think we're good. I want to leave time.
All right, so we're going to move to the question and answer portion of the session. So first off, thank you to Bert for all of the relevant information. Before we do open the floor to questions, and just a reminder to everyone, if you have a question, type it into that chat or questions window on the bottom of your control panel, and I'll pass them over to Bert, and we'll get as many of them answered as we can. While you're doing that, I do want to take this opportunity to share a little bit about MDeverywhere. We do provide ICD-10 ready, purpose-built revenue cycle management technology, along with a full suite of claims processing and back-end services to help physicians, in addition to a 2014 certified stage 1 and stage 2, 2014 certified EHR solution, fully integrated, so you're getting the RCM technology and the EMR in a single source solution for all your revenue cycle and EMR needs. And our solutions are designed to aid clients in meeting guidelines and maximize revenue for all the patient visits. All right. I do want to again reinforce, did I mention, and I want to make sure you heard me, ICD-10, are you ICD-10 ready? Next week is March. October is going to be here very, very quickly. And I do want to point out we are ICD-10 ready. We've already rolled out our ICD-10 environment to our clients. They're working in it. They're playing with it and testing it at no upgrade cost to our clients. So if you're still waiting for your vendor to deliver an ICD-10 sandbox, training tool, software application, just be aware that the clock is ticking and you're going to end up getting jammed up. So just be aware of that. Okay. In addition to being RCM and EMR, MDeverywhere also has an NCQA certified CBO and full credentialing division, truly making us a full-service company. We've partnered with about 7,000 physicians across our different lines of business nationwide, 40 different specialties, and we really can be your single-source solution if you are looking for a partner who will help you navigate this very all the changes that we're dealing with right now. All right? So enough about us. Let's get to you. Let's get to your questions. And again, if for anyone who has a question, just type it in that chat window. We still have time left, and we'll get to as many as we can. Bert, we do have our first question submitted. All right. What is value-based purchasing? What exactly does that mean?
Thank you, Ellen. Excellent question. And it is the term is bandied about. To try and make it a little concrete, what it means is that, or whether it's Medicare or commercial plans, they're looking at data that they believe signifies the quality of outcomes. So examples of outcome measures, depending on whether you're a primary care doctor or specialist, might be post-operative complication rates, length of stay in the hospital for a given condition. It may be frequency of admission for patients with chronic diseases. It may be routine management of conditions, compliance to medication, quality data that is relatively objective and can be collected, especially easily by Medicare, but also increasingly by managed care plans. That value index is then compared to the cost. It may be the cost of an episode of care, for example, an open heart surgery, or it may be the cost of all care for a patient with diabetes over the course of a year, but it becomes, in effect, a ratio that can be benchmarked and said, on average, for this type of patient, the cost or the outcome index should look like this relative to a cost of that. And benchmarking will be used to determine whether individual providers are delivering value. Now, this is obviously quite a challenge, because if the payers are looking at this, you need to be keeping your eye on it as practices and making sure that you are able to collect the data and know in advance how to interpret what's being said to you and manage against it. Helen, other questions?
Yeah, we do have a couple of others, okay? We have a question from a specialist. How does primary care content, how does this primary care content impact a non-PCP specialty? Let's say I'm a cardiologist or a GI. What does this mean to me?
Excellent. Yes. I think that is an important question to bear in mind, because a lot of it looks right now very primary care oriented. I believe that the answer lies in the pressure or expectation that's going to be placed on the primary care providers to deliver that idea of value. And so as data emerges about specialist performance, who refers to you, and if they are becoming medical homes, if they are taking on risk, or if they're part of an ACO and sharing in the savings while maintaining quality standards, who a primary care practice refers to is going to be influenced significantly by these changing modes of reimbursement. I would also submit that package pricing is growing rapidly and dramatically over the next several years, so those core abilities to work with patients to manage the costs, particularly including the post-acute period, are going to be significant if you specialist practices are able to access some of those shared savings. I also believe that we'll see for frontline specialists, let's say cardiologists or pulmonologists managing their patients with, say, heart failure or COPD, we will see some of these ideas of medical home shifted to include specialists.
All right. Watching the clock, we have time for just one more question, and it's a two-parter for you, Bert. Why is Medicare or other payers looking at this medical home model? What are they really after, and how does it affect my business? Go ahead. Sorry.
Thank you. No, thank you. And the thrust behind the medical home model is this core idea of, again, to use the term, delivering value. It's to get the providers, in this case primary care providers, to really engage with their patients, to make sure that they are not simply reacting after the fact to changes in health status, but anticipating the impact of the patient's underlying conditions and working proactively to manage the outcome of their care. And this is the intrinsic goal of all of these initiatives, basically to use technology, medical technology, to the result of better outcomes with fewer high-cost interventions, such as hospitalizations or emergency room visits. And again, I believe this will gradually expand into the world of specialists to, again, create value. And for the practices represented on the phone, your ability to demonstrate this value, to deliver accordingly, and to anticipate what the payers are going to be offering or saying to you is very important in managing your future revenue streams. Ellen?
Thank you very much, Bert. That will wrap it up for this webinar, everyone. In closing, I do want to thank you all for your time today. We will continue to offer information to help you improve your revenue cycle management process, as well as helping to understand the changes that are happening in our industry that are directly impacting practices in the hospital industry. If you would like more information about MDeverywhere, you can email us at questions@mdeverywhere.com or visit our website at www.mdeverywhere.com. We've got a pretty active blog out there with lots of relevant information, so I do ask you to visit there that actually can give you some insight into the changes you're dealing with. Of course, contact Bert Orlov at Integrated Healthcare for more information about payment reform and the other consultant services that IHC provides that could also benefit your organization. Any questions that were submitted but not aired, we will follow up with. And as I mentioned at the start of the presentation, you will get an email follow-up with a link to the recorded webinar, and it'll include a link to download a copy, PDF of Bert's presentation. I do want to invite you to watch for announcements of upcoming MDeverywhere webinars. As a matter of fact, our next one is an express webinar scheduled for 3 o'clock today. It takes about 15 minutes, and we're going to be covering credentialing's top 10 mistakes. You can register on the MDeveryware website right on the home page. Just go all the way down to the bottom. You'll see events, and you can click on that link and register for the credentialing top 10 mistakes. That's today at 3 o'clock. March topics that we have on the calendar, the GEMS Cross D9 and ICD-10. That's the 5th. One right now we've got on the schedule for March will be a session on the HIPAA omnibus ruling. We have our legal consultant, Jennifer Kirschenbaum, with Kirschenbaum & Kirschenbaum, who will be presenting that content. Again, you can register on the webpage, on that homepage of the webpage. Thank you again, Bert. Terrific information, great content. Thank you to all our attendees for the time today. And this will end the webinar. Enjoy the rest of your day. Thank you, everybody.